Thank you very much, Pat and Jeannie, for that very wonderful talk. So, we have a couple of questions in the chat. So now we can ask them to you. So the first question from Elena: how would you use the harm reduction approach with drug users who are very poor? Many of the drug users we interviewed were faced with a lot of economic issues, unemployment, underemployment, and the stresses of their poverty-ridden lives. So, how do you advise our people on the ground on how to actually use harm reduction approach with these people?
Well, the program that I described is for people who are very, very poor, who have no income or very low income, who have no housing usually. And that's why we bring so many different services to the same site. What I didn't mention is that we also have economic benefits counseling, as well as assistance with referring people to job training programs, in addition to assistance with finding housing, which is very difficult. I don't know about the Philippines, but it's very difficult in the United States, and particularly in San Francisco. But it's important to have a multidisciplinary team where a person can get whatever service they need, whether it's emotional support or practical assistance with, food, money, and housing. And one of the things that we find is that people will need something different every day. And the more, and Pat talked about this in the principles, the more a person has choice in every moment, the more motivated they are, and the more they get better. So having a multidisciplinary team that can address many different issues allows the person to walk in and choose something that they need that day, or something that they're motivated to engage in that day. In general, harm reduction therapy was developed for everyone who uses drugs who is not ready for or not interested in a more traditional abstinence-based approach. And at HRTC, we do both. We work with people who do have resources and money and homes, and we work, more often with people who do not. So I hope that helps.
Yeah. I also want to add something about the sort of the multidisciplinary team. We at the Harm Reduction Therapy Center are therapists. We're clinicians. We do not, in our organization, we do not have job specialists or case managers or all of this other stuff. So we partner with other agencies, but I think it's really important that, that that somebody needs to set the culture for all of the providers. Because therapists have a certain way of talking with people, but attorneys have a different way. And case managers might have a different way. And somebody really needs to be in charge of setting the culture of welcoming people and being accepting of who they are. And unfortunately, there are a lot of different organizations or agencies that may not share your values in that way. And so somebody needs to be sort of at the top of the hierarchy, if you will, to set the culture.
I think you've addressed a couple of our questions here, and I'd like to follow up on the multidisciplinary team. So here in the Philippines, it's the culture is not that welcoming, or is not yet aware, I would say, of harm reduction principles. So collaborating with staff and when co-locating your services, I'd like to know, how did you start the conversation with other service providers who might not be that welcoming of drugs and drug use and the harm reduction approach?
Over the last 20 or 25 years, we've done an enormous amount of training for organizations that are new to harm reduction. I think the most powerful thing to do is to just start by asking other providers what they're worried about, what they're concerned about, what they're having trouble with, and to listen. And instead of going right in and talking about harm reduction, ask them what they've tried. And this is the same thing we would do with a client. Well, what have you tried? What's worked, what hasn't worked? Why do you think it hasn't worked? And then have you ever thought about working with someone while they're still using, rather than asking them to stop before they come to your program? Now, usually in our experience, the answer is no. Not anymore. We're more mainstream in the United States now. But
well,
in California.
Yeah, I think there is a little bit of a misconception about how harm reduction is accepted or not in the United States, and even in San Francisco, it is still extremely controversial. It is not mainstream. It's becoming mainstream in terms of the Department of Public Health and the behavioral health services, but it's still really controversial.
I'm more optimistic than that is, but anyway.
Okay, so we have another question here regarding your startup story. How long did it take for the program to become mainstream? So now we're talking about mainstreaming, harm reduction. So what caused its broad acceptance? What do you think made the people accept the services that you've offered them?
Oh, well, that's I guess I have to ask, is the question about engaging potential clients, or is the question about other providers and the public?
I think it's both. So the society accepting the harm reduction approach, and actually the clients who need them. How did you have them accept this as part of as a choice to their treatment or to recovery?
Well, for clients, once they experience the acceptance, the unconditional acceptance, and once they experience somebody saying, "What do you need?" and I'm actually not going to tell you what to do. I want to hear what you're worried about. Most clients are immediately converted. Some are still suspicious. Some don't. And Pat, maybe you could address that. Some people don't. They don't think we're worried about them if we're not telling them what to do.
Mm-hmm. Right. Yes, we've had that. Particularly in people who have some resources in their lives but have a really serious drug problem. The fact that we are not criticizing and punishing and controlling them, some people it feels to them like we don't care, mm-hmm. or that we don't get it. Mm-hmm. How you don't get how bad my drinking is, or you wouldn't be so nice to me. Mm-hmm. And that's a really tough one.
Yeah. And that's a culture. I mean, that's
a culture.
I mean, that's the culture. Unfortunately, the culture of drug use and drinking, particularly illicit drug use, around the world. Mm-hmm. And the United States is responsible for that culture. Really, we have exported it all over the world. That culture, that value. But Pat also could talk about this. Families are a big group of concern, because families are usually worried before the person who uses drugs is worried. And families are looking for solutions. And Pat has a lot of experience of working with families and helping them come to understand how harm reduction might seem like we're not doing very much, but actually may lead to better change than continuing to fight, a battle of control. So if you want to say more about it.
Yeah, I think that, and I think it's up in our booth. We have a few different articles, and one of the articles is a article that I wrote about using harm reduction and helping family and friends of drug users. And to me, one of the most important things is to attempt to create an alternative to tough love, and create a situation where families get to choose and make different choices based on their own values rather than on what society or what some treatment center tells them. Um, so, so that's an article for people to look into. But I think it's just, just like it doesn't help drug users to control and tell them what to do.
Yeah, thank you very much for that. We had an idea on how to actually engage our patients and their clients as well. So there's a follow up on that question, and this is for the funders. So how did you get continuous support for the funders?
Well,
that's Jeannie's job.
Right. You know, I have to say, we've been doing this work as an organization for more than 20 years. And it was not until, and we've worked, our funding has come from small organizations that hired us, often for a very small amount of money, to bring our services to their organization, as I was describing, going into other people's drop-in centers and seeing and working with their clients, providing treatment services to the clients of social service agencies. We did that for 17 years before the city of San Francisco approached us to work for the Department of Public Health. It was not quick. But we had, once they did approach us and once they did decide to give us a grant, our reputation was so good that they said, we trust you to figure out how to create new programs on the streets for people who are experiencing homelessness and using drugs on the streets. So we have a lot of trust. Over the last 3 years, we have been given increasing amounts of money. And, I think we do the same thing that we do with our clients, is that we keep talking, we maintain close relationships, we include them. I do have a photograph. It's not in the video that we produced, but there's a beautiful photograph of the Deputy Director of Community Behavioral Health Services kneeling on the ground at one of our sites, washing the dishes. And she said it was one of the best days that she had the whole year, was on the streets with us washing the dishes. So we're very welcoming of our funders. We're very welcoming of the person who cooks the food. And this is a great little story. One organization which is actually involved in moving people's tents off the streets. It's called the Department of Public Works. The individual workers know who we are from the Department of Public Works, and the person who prepares our food, Winnie finds out what everybody likes to eat. She can cook 300 individualized meals in a week. And yesterday, at one of our street sites, one of the drivers of one of the Department of Public Works trucks came by and said, "Winnie, what's for lunch today?" And she said, "Oh, I made a special lunch for you because I know you don't like spicy sauce. So I made you." We really literally treat everybody the same. So Winnie runs over to the truck and hands a city worker a lunch that she specially made for him because she knows what he likes and what he doesn't like.
Yeah.
And the director of Public Works, at our first site, there was a big homeless encampment clearing, and it was raining, and the bulldozers were literally bulldozing people's tents and throwing their belongings into big trucks. And we went out and we put up a canopy, and we cooked soup, and I had made bread, and we're just giving it to everybody. And the police and the public works staff came over and they very quietly said, "Can we have some too?" And we said, "Well, of course." And the director stood back and he said, "Oh my God, you have created a neutral space where we can all just be people together. This is going to change how people think about people who are homeless."
Thank you. That's a very inspiring story, Jeannie. There's another one here that I think is a very basic question on how to really go about harm reduction here in the Philippines. So, how do you think the Philippines can overcome the stigma of drug use? So, uh, she said here drug use is heavily penalized and a number of people are even incarcerated. So a lot of people are incarcerated because of drug use here in the Philippines. So it's kind of very traditional and punitive. So what's your advice for us here in the Philippines on how to actually overcome the stigma of drug use?
How about the basic harm reduction training?
Yeah, I think that one of the important things, and again, we're clinical people, and so we sort of think with that lens, but we also understand that society and the United States war on drugs, which we've exported everywhere, has an incredible effect on people, and that we always have to be both providers of services and activists, and that we can't just we can't just go around trying to provide services without also being active politically. And I think one of the main things is the basic principles of harm reduction. It's hard to argue against the basic principles of harm reduction. And if you can get people thinking about humanity and people's needs rather than bad drugs, that's a good place to start. And you use whatever is important in your own culture also. If there are cultural um, rituals that are important, if there are religious things that are really important, that you find a way of using what people already believe in and adding a harm reduction lens to that, so that you're not asking them to be different. You're not asking them to give up their religion or give up their beliefs or give up their heritage.
Mhm.
You're just asking people to expand it and to look at it a little bit differently.
I think people respond well to being asked to be compassionate.
Yeah.
I'm thinking about the Reverend Edmund Saunders.
Oh, yeah.
A long time ago, when harm reduction was very little known and it was illegal, very stigmatized. The pastor of a large church in Nashville, Tennessee, which is in the South in the United States, very conservative. And the church was an African American church. And the concern of that pastor was for church members who had HIV. And HIV was very stigmatized in the African American community. And he decided that he was going to make the church's mission to become a syringe access program, a needle exchange program, and he started making syringe packs in the basement of the church.
Mm-hmm.
And he told the older women in the church that their service was going to be making syringe packs for people who use drugs as an HIV prevention strategy.
And boy, did he got a lot of, no, 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 we can't do that. And he just worked with people with compassion.
And love.
And love.
Yeah.
Yeah.
And he said, we can't exclude our members, our children, our cousins, our fathers, our mothers, our aunts and uncles. We can't exclude them just because we don't like what they do. And this is the best way to take care of them. So he just went in with compassion and love.
that sounds very practical, and that concept of compassion and love becoming more practical in our ways of harm reduction is really very concrete in how we actually can go about this. Actually, going from the community, another question here is that how can you use the harm reduction to clients who are having their inpatient rehabilitation because it is mandated by the court. So we've had a couple of discussions about coming as you are, being not coercive, but despite that being mandated by the law or the court, how can you suggest to go about harm reduction therapy in these patients or clients?
I think that actually it's not that hard. It really means really thinking again about what are the principles of harm reduction. So what you want to do with people, they're in an inpatient unit, they're not supposed to use, they're not using, they don't have access to drugs. And so the important thing is to be really respectful of the fact that you've been using drugs, and there are probably really good reasons why you were using drugs, and there are harms that you suffered, and we want to respect all of that. So, and especially while you're here and you're not using, this is a time when maybe your head is a little bit clearer, and you can begin to think about the benefits that you got and the harms, and start weighing how you want your life to be in the future, and to give people the message also that that you understand that once they're out, they may make different choices. And with that understanding, then part of the inpatient treatment needs to be about overdose prevention and safer use and moderation. You can't just assume that the person is always going to be abstinent once they leave.
There's another follow-up here regarding that question. Do you think substance users who do crime under the influence should be held accountable, or should they be treated as patients or clients?
I
Or
think
is
both.
that, yeah?
I think both. I mean, they've done something illegal. I think that that it's a mitigating factor that they might have been under the influence, and so I think there has to be some subtlety in it. But if they're harming society, harm reduction is meant to help both reduce harm to individuals, but also to families and communities. Mm-hmm. And unfortunately, sometimes we come down on the side of reducing harm to communities by having criminal sanctions.
And we don't agree with criminal sanctions for drug use. And we understand that people commit crimes because they don't have any money. Well, there are crimes of violence that happen while people are under the influence because of the in part the influence of the drugs themselves. People get to make choices, and they also need to learn to consider that some of the choices that they make may have consequences. And a good harm reduction counselor will be realistic about the environment. And the Philippines is a very punitive and a very coercive environment. And so, we can still talk honestly with people about, you get to make your choices, and the consequences here in the Philippines can be really, really terrible. How do you feel about that? So we actually, as counselors, help people to evaluate their choices. That's very difficult when you are traumatized, and drugs are relieving. They relieve you the symptoms of trauma, and you're very caught up. It's really about counseling people about life while they're using drugs. Mm-hmm. And so the fundamental, principle of harm reduction is to start wherever you can. Don't exclude people who are using drugs from yours, and have real conversations.
So it really boils down with the main principles of harm reduction. And to add to that question, I'd like to ask for the principle of come as you are. It is easy to actually accept people and apply this to our practice. But because we do not have a preset goal or a time limit, can you share how you motivate people towards getting or towards working on their own goals? So how do you actually go about motivating your clients?
By asking them what they want, by asking them what they need. You know, one of the fundamental evidence-based models that supports harm reduction therapy is self-determination theory. And self-determination theory is a very well-researched concept that says that when people have autonomy and choice, they are both more motivated and they're healthier. So having choice actually leads to better choices. Having choice leads to motivation.
Mhm.
Communicating to people that they have choice actually makes them more motivated. In Europe, where they're not as punitive as the United States or the Philippines, when people were offered in research, people were offered the choice of abstinence goals from their drugs or moderation goals. When people were given a choice, they actually achieved abstinence more successfully than when people were not given a choice. And so, you know, I guess that's another argument for people who resist harm reduction, because harm reduction is based on very solid evidence. Plugging in our computer. Is based on very solid evidence that choice actually helps people to make progress. And it doesn't seem like it will, but it does.
Okay, thank you very much for that. So we really go back to what they want, right? And how to actually motivate themselves to actually move towards that goal. Logistics-wise, what can you suggest to our practitioners in making their programs more cost effective while accommodating family members and accepting the most people that they can get uh, from the community? So what can you suggest about making your program more cost effective? Because here in the Philippines, we have very limited resources, and I'd like to ask what your idea about these things, because I saw that you have very good innovative, practices there, and I think this would really help us here in the Philippines.
You know, I think one of the things is by having the services be as flexible as possible, so that you're not wasting time or staff resources. And some of that means that you have individual sessions that are different lengths. You have small groups, you have large groups, so that and you have drop-in hours.
Drop-in services.
Drop-in services is an incredible way to maximize the number of people that you can work with in a particular day. I mean, our staff, when they're on outreach, they may have contact with, now that's not necessarily a sit down session. They may have contact with 30 people in a day, and be able to offer a little bit of advice or a little bit of compassion, or answer questions. So I think the more flexible and the more quickly you can respond to different community needs, you can maximize your resources.
You also, I think, need to spend less money on inpatient or rehab or residential.
Yeah,
That's very expensive.
yeah.
And it's not very effective. It makes people feel better because you can establish control for a while, but it's inefficient, it's not effective, and it's very expensive.
Mm-hmm.
Treating more people in an outpatient setting, and as Pat said, making it all drop in. You know, we have a medical clinic here that does not use an appointment system. It uses what's called an open access system, where the patient is told, your doctor will be here every Wednesday morning, come back on a Wednesday within the next month. Very, very casual, because so that the patient can remember. And that clinic is able to see many more patients because they don't have an appointment system. And in an appointment system, you might make, for a doctor, 15 appointments during a morning, but half of those patients won't show up. If you have an open access system, you can actually see 15 or 20 patients in a morning because they just come. And so the less we structure things, the more people can come in the door, and the more we can work with people at the level where they are, which is also harm reduction. So yeah, drop in, open access, no rehab, and multidisciplinary, so that people can get what they need. I mean, we see hundreds of people every week, and we only have a team of like 10, not even 10, 7 or 8 therapists right now.
Yeah.
Hundreds of people every week, and some people get little contact several times a week, and because everybody's moving at a different pace. Very efficient.
Right. So some clients will show up every day and spend 5 minutes. And other clients, they may get a full session, a full 45 or 50-minute session. But it's just we're just so quickly responsive to what people need. And I think that's really different than traditional treatment, where, especially in therapy, where the therapist is the one who sets the time limit. And a lot of our folks, a lot of people with a lot of trauma who are heavily using drugs, they can't stand to sit still that long. They can't stand to talk about themselves for that long. And so if we're able to say, well, what, you've only been here for 5 minutes, we've got more time. And they say, well, no, to let people go. We don't need to spend 20 minutes, 30 minutes.
Okay, so
and over time, people will ask for more.
So engaging them with this flexibility is actually cost effective.
Yes,
extremely cost effective. I can tell you how many more people we see than other programs.
Yeah. And
it's
again,
amazing.
Reminder, there are only about, 8 to 10 therapists in our organization, and we see hundreds of people a week.
Now, I worked in my first exposure to substance use treatment was in an inpatient, a 2-week detox and stabilization program. And the social worker who did the intakes would have about a 5-minute conversation with a prospective patient, and then say, come in next Tuesday at 9:00. And I would say, why didn't you do a full intake? And he said, because it doesn't matter. It won't make any difference. If the person says he wants to come in, I'm going to tell him to come in next Tuesday whenever we have the next opening. And I'm going to schedule 2 or 3 people as backups. Because if he doesn't show up, I'm going to call the next person and say, if you can come over by noon, we have a bed for you. And it won't help to do a screening interview. It won't change his motivation. In fact, it might make his motivation or her motivation go down. And that was also kind of like this open access clinic, but in an inpatient program. And then whoever wanted to come in would come in and be there, and that was the person who was most motivated to be there. We were always full. We never had empty beds. Never, ever, ever, because we didn't wait.
So no waiting times, right? That's I think great for both practitioner and their clients. So we have another question here before we wrap up our session. What are the best tips that you can give us to ensure that a client or patient with problematic drug use and had been helped to manage his usage from relapsing and losing control again? So how do you go about relapse and, helping them towards really getting towards that goal of not relapsing?
I think that that really is a treatment question, and one of the really important things is, again, to allow people to talk about the benefits of their drug use and what they will miss by not using or by using less. And to emphasize that as just as much as you emphasize the problems, so that they're not hiding, they're not hiding from what they're going to miss. It's really, I like it when I'm drunk because I don't think about anything else. I like it when I'm high because I can flirt and have more fun. So to honor that people are using drugs for reasons helps inoculate them against those situations that they're going to have to face. So that's sort of the first thing. The second thing then is to actually teach people skills. What is it that's going to be hard for you? Is it going to be hard for you to go see your father? Is it going to be hard for you to go to a party? Is it going to be hard for you to know that you have to have surgery and you're afraid of it? To plan, to help people plan, because if all you're saying to a person is don't use, and all the person is saying I'm not going to use, then they have no skills when confronted by their real life.
Yeah. So let's make harm reduction practical for our clients by giving them skills to actually go about their drug use and drugs, or for that matter, for their everyday lives, right? Just go
Yes.
into their everyday lives. Yeah. So to end our session, Pat and Jeannie, do you have any last key message, especially to our audience for working directly with people who use drugs?
The only thing I want to say is that I want to give a huge thank you to all of you who've put together this conference, for all of you who've been working in the field. And Jeannie and I met Inez, I don't know, a million years ago, and have been hoping that she's been able to stay alive and happy through all of the hard work she's done. So I just want to say to Inez, thank you for all the work you've done, and that I'm happy that I could provide any help that I can.
And what I'd like to say is to let yourself, and this is something that we teach when we teach about how hard the work is and how to sustain it. Let yourself have at least some fun with at least one client every day. Laugh every day. Let yourself feel love for the people that you work with, even if you don't directly say it. Let yourself feel it, because those are the things that are going to actually keep you alive and keep you connected to the work and keep you connected to the people that you work with. And it will allow you to do this work for years and decades.